So I'm going to talk to you a bit about a cardiologist's journey to low carb, and this is just a brief summary slide about some of the things I'm going to be talking about. And this is a slide modified from Dr. Asim Malhotra, was published in the British Journal of Sports Medicine last year, along with Rita Redberg, who's sort of editor of the Annals of Adult Internal Medicine, and it talks a bit about some of the diet and lifestyle factors in terms of coronary artery disease prevention. And coronary artery disease is only one aspect of heart disease. The other aspects that have been talked before about are things like high blood pressure, and I'm going to talk a little bit about atrial fibrillation. But I think the other really big aspect that maybe has not been mentioned enough is the effects on the brain as well. When we talk about the effects on the heart, we're also got to think about the effects on the brain and the long-term effects of the brain of diabetes and high blood pressure. And I want to focus on the lower part of the diagram, because that's where a lot of low carbohydrate makes a really big difference in my patients and in a lot of you. That it's fantastic at treating insulin resistance, type 2 diabetes, combating this concept called atherogenic dyslipidemia. I'll talk a little bit about it. This is where you have more atherogenic lipid particles. I'll talk a little about LDL subfractions. And then insulin resistance leads to hypertension, leads to atrial fibrillation. Paul Mason talks about suboptimal omega-3, too much omega-6. We often measure in a lot of our patients. So, how do we get a journey to low carb and lifestyle prevention of heart disease? So, as has been mentioned before by Dr. Branca, in medical school we had very little training in nutrition. I think we actually had 3 lectures. I went to UNSW, and I think I probably skipped 2 or 3 of those. We didn't think they were that important. We wanted to learn how to treat disease. Then I did an internal medicine residency where we learned how to treat disease, a lot of sick people, yet often people come in with heart disease, complications from diabetes, and these people were fairly end-staged. And then I did cardiology training just up here at Royal Prince Alfred Hospital, attached to Sydney University, in an academic cardiology program. And I spent 3 years treating heart attacks, acute heart failure, strokes, and spent a lot of time getting to treat the really sick people, but didn't get to learn a lot about how to treat them at the other end or how to prevent them. So that's how I got started on my journey. And I've been very lucky to be associated with Doran and Paul Mason, who have sort of brought me along on this journey, and been, in fact, relearning what we've been taught for many years about cardiovascular risk factors, about styles of eating. Well, the only thing we learned was about the low fat. And low fat was good for heart disease, yet we're seeing more heart disease, more obesity, more high blood pressure, more atrial fibrillation. It's actually not reducing the burden of heart disease. So for me, it's a journey of moving away from our traditional teaching and learning some new ways of treating disease. And the great thing for me was patients were actually getting results, and it's very heartening to see a few of my patients here, and to Ian over who came to speak, to get results where for years they were not getting results from traditional methods, from getting traditional advice from dietitians or the doctors. They were not getting the results. And until I started working with the low carb way of eating and Dr. Mason, patients did not lose a significant amount of weight. I'm going to show you some examples of some of my patients who've done fantastically and reversed aspects of their heart disease. And one of the major things is reducing or eliminating type 2 diabetes. Now, when you think about over the age of 50, type 2 diabetes is one of the most important risk factors for development of coronary artery disease. And if you've had a cardiac event or if you've had coronary artery bypass surgery, uncontrolled diabetes is the major risk factor for the recurrence of heart disease down the track. And I'm sure a lot of you who've been involved in this movement know about the amazing effect at reducing diabetic parameters, reducing HbA1c, reducing fasting glucose, treating the metabolic syndrome. And I mean, you just sort of see, some of you who know in the diabetic field know about the plethora of diabetic drugs that have come on the market in the last few years. They keep on coming up with new diabetic drugs, they keep on coming up with new studies to try and show the reduction in cardiovascular outcomes. But how about eliminating diabetes altogether and not putting people on the medication, or even Ian talks about getting a gastric sleeve operation. Well, a lot of people are resorting to having half their stomachs cut out to try and lose weight, and then even it doesn't sort of have long-lasting effects. The other thing in low-carb cardiology, trend move towards low-carb, is a way of personalized medicine. So for some of you who start on low-carb diet plan, you'll see that you'll get a lot of parameters measured at the start. You'll get your omega-3 index, you'll get your LDL subfractions, you'll get your HSCRP. If you come to see me, I'm going to talk a bit about calcium scoring. But we measure where you are. We get a very clear idea about what your risk is. And then we want to be able to measure parameters as well, to see how you're doing and to see what effect it's having on you. Because we are all so different in so many ways in terms of how our bodies handle food, how our genetics handle food, our liver handles food. And we need to get very good at and get an idea about how our bodies respond to a certain type of eating. The other great thing is we work together with other committed healthcare providers, so as a team in terms of your health. And I'm really looking forward to further outcome studies which are being done, and I'm going to show you one that's been published, and also being able to follow patients on this and seeing how they do. So this is just a very brief story about atherosclerosis. So atherosclerosis is the precursor to coronary artery disease. So this is what causes most of the problems in Western society. And it starts off, you see on the thing, a type 2 lesion. So this is where you've got no plaque. And gradually plaque starts to form in the arteries. Initially, you start to get soft plaque form in your arteries, in the coronary arteries, the arteries that supply the heart. And then you start to get what's called non-calcified plaque. All of this time, your calcium score is still 0, and this happens as a gradual process over many years. And it's a dynamic process. Plaque is going into the arteries and being taken away, and over the course of time, this plaque starts to harden. When it hardens, it starts to calcify, and that's when it can be picked up on sort of non-invasive imaging, which is my other area of interest. And when you start to get sort of very unhealthy plaque, that is plaque that has a lipid-rich core, plaque that is unstable, that's what causes a heart attack. So in the type 6 complicated lesions, that's basically what causes a heart attack. And for about a quarter of men, they have coronary artery disease. Their first presentation of heart disease is their heart attack. And it would not have caused symptoms because that particular plaque is not causing a narrowing. And what I do, it's very important to pick up early signs of disease and put people on the appropriate management. So that's briefly, atherosclerosis is a gradual process. It takes many, many years to build up in the arteries, and often in many people it starts in their 20s. So, calcium scoring is a way to detect atherosclerosis, and it's a great test. It's a low radiation CT scan of your heart. It takes about 10 seconds to do in most modern CT scanners. It costs, unfortunately, the Medicare are not rebating this test yet. It costs anywhere between $100 to $200. You don't need a specialist referral to get it. You can ask your GP for it. In actual fact, you could probably just go request one yourself. To get one, any large radiology provider, and it basically looks for the presence of the disease, and the disease is atherosclerosis. So what the calcium score does is it integrates your genetics, your risk factors, your nutritional risk factors, all into something you can actually see. You can actually see it in the arteries. Instead of looking at surrogate markers, we actually look for the presence of disease, and it takes everything into account. So these are some examples of some coronary artery scans. So this is no calcification. So the radiation dose is 2 chest x-rays, so it's really very minimal. This person has some calcification, and then this particular person has a lot of plaque. So this person is higher risk, and the higher your calcium score, the greater risk you are for vascular events. And this particular person is an example of a patient. He's got a calcium score, and it's called the Agustin score. Agustin's the author of one of the diets in the 90s, and it was the South Beach diet, but he came up with a score as well. This score is 2,000. So this is a very high calcium score. This person's got a lot of disease in his arteries. What affects calcium scores? And these are some of the factors when you look at very large studies of populations, what can affect it. And I'm going to focus on a couple of things. Increased body mass index in middle age, high blood pressure. diabetes, metabolic syndrome. Microalbuminuria is a consequence of, in the majority of populations, of diabetes and high blood pressure. An abnormal lipoprotein profile, so more type B pattern, more atherogenic LDL, high triglycerides, lower HDL. Increased inflammatory markers, so for those who I'd urge you to think about getting a high sensitivity CRP. And this, looking at CRP was sort of in vogue around 10 years ago. That's because one of the companies published a study that showed that statins reduce CRP. We're seeing it in a lot more interest now because we know that if we reduce inflammation, we reduce the chance of someone having a cardiovascular event. And actually, there's some very expensive ways to lower CRP, but I think there are some less expensive ways with lifestyle. Renal dysfunction, so the most common cause of renal dysfunction, kidney problems in our society is hypertension and diabetes. And then males often have a little bit more calcium than females. And the calcium score is a great predictor of vascular events, and we measure it in, if you're 0, you're in great shape, your risk is very low. 1 to 100, you've got very mild plaque, and anything above 300, you have a 10-fold increase of having a cardiovascular event over the next 10 years. And this is just a very brief interpretation of what your calcium might mean. Your FRS equivalent is basically your risk profile equivalent. But if you have a calcium score of 0, the 10-year event rate is actually, I think it's actually lower than probably 1%. And as you sort of get your calcium score above 100, you have above sort of 400, you have a 1 in 5 chance of having a heart attack over the next 10 years without intervention. So as a cardiologist, this is a little bit of a complicated slide. I'm going to talk to you a little bit about the rationale for showing it to you. I'm the cardiologist that takes people off statins. For many years, there was a knee-jerk reaction. Whenever you had a high cholesterol, you went to see your doctor, you got a high cholesterol, you better go on a statin, right? So the disease is not necessarily high cholesterol. The disease is what the calcium score shows you is atherosclerosis. Right, so if you don't have atherosclerosis, you do not need, and if your calcium score is very low, you do not need to go on statin therapy. And I just want to think about that. So all these people, in my opinion, were being put on statins inappropriately and going on a chronic long-term medication for many years, if not life, for no particular reason. So we can better personalize the prescription of statins by using imaging such as calcium scoring. And there are currently guidelines that published by the large cardiac societies such as the American Heart Association, the American College of Cardiology, and we have our own guidelines in Australia, where they recommend statins if your 10-year risk for a vascular event is over 7.5%. So I'm going to show you that this is where it says recommend statin in the red, where your 10-year risk is 7.5 to 20%. So when you use calcium scoring to help reclassify these patients, about almost half of these people that would have been recommended statins under traditional guidelines have a calcium score of 0 and they do not need statin therapy. These people then fall into a low risk category. So if you are on statins, just for high cholesterol, I'd speak to your doctor about getting, if appropriate, a coronary artery calcium score. Even in the very high risk people, where your risk is above 20%, and when your risk is about 20%, you do have to pay very close attention to your risk factors. But even some of them, even a quarter of them had a zero calcium score as well. So using imaging, like we do, allows us to reclassify who may need to go on statins and avoids inappropriate prescription. Right? So this slide says about elderly people, but in elderly, this was a study looked at people over the age of 60, I don't know why they used 60 in elderly. But we looked at subclinical, so we used people who may be statin eligible. And unfortunately, in the guidelines, the older you are, the more likely you are. The guidelines will say you should get a statin. And this was used to look for subclinical atherosclerosis, look at coronary artery calcium scoring, and use a disease-guided reclassification. And so this allowed a much better redistribution of statins, less overall statin usage, and reclassifying people into appropriate risk score groups. So when is it reasonable to do a coronary artery calcium score? For men, I think over the age of 45, it's very reasonable to do. Or if you're over 40, then you have quite a few risk factors for heart disease, especially if you have a strong family history where you've got any of the traditional risk factors for heart disease. For women, around the time of menopause or potentially earlier if you have a very strong family history or risk factors. And also, if your risk score, and I'm going to show you a calculator where you can calculate your own risk score, lies around 5 to 20%. And it's very helpful, as I showed in the last slide, it can reclassify you into very low risk if your calcium score is 0, or if your calcium score happens to be higher, you fall into a high risk category. So I put this website up for two things. The first is, it's called CHD Best Science Medicine, and it's a wonderful website for calculating your personal cardiovascular risk. You can put in your numbers, and there's 4 ways of classifying your risk on this website. The one I'd use is there's New Zealand guidelines or the ACC, AHA guidelines. And it also allows you to look at the interventions. So I want you to see, what you can do is you can show your doctor, look at yourselves, about the absolute benefit of statins in low-risk people. And you'll see that the number needed to treat in low-risk people is very high, often more than 100 or 150 to make any difference. That means you have to treat 150 people with statins to make any difference in cardiovascular outcomes. And you'll also see the effect of lifestyle and diet on reducing your risk in that low area. And then if you've got a calcium score, plug it into the risk score calculator below, and that allows you to plug that calcium score into your risk factors and allows you to calculate your risk score exactly. And if your 10-year risk is not above 10%, or your calcium score is not greater than the 75th risk percentile, on that calculator allows you to see where you fall into age and sex match cohorts, then there's limited benefits of statins to reduce cardiovascular risk compared to diet and lifestyle change. And so 0 calcium score is pretty priceless in terms of reducing your risk. All right, so I often get asked a lot about, diet to prevent heart disease, and this has been a journey that I've had to learn as a consultant because, as I said, we're not taught very much about it. I guess one of the things that I guess the low-carb movement has been great about, and this is about actually examining some of the diet studies very carefully. It's called for a greater rigor in how we look at diet studies and greater analysis. So diet studies focus on macronutrients, but people don't eat macronutrients in isolation. They consume food as part of an overall dietary pattern. And for example, the carbohydrate content of a large bowl of fruit and vegetables is maybe similar to cornflakes, but its effect on health is very different and in your body. Randomized studies of dietary interventions are very difficult to do. You need very many patients to do it, often greater than 5 or 10,000 in each arm. These are very difficult to be funded because most of these large studies are funded by pharmaceutical companies. If you're just doing observational studies, they're limited with uncertainty. Many studies rely on food surveys, and food surveys are notoriously unreliable. And also, you'd be surprised at the very low frequency the food surveys were actually filled in for some of these diet studies. And people in food are very diverse in very many ways, as I sort of spoke about. And ideally, if we're looking at diets, we can look at systemic reviews or meta-analyses. And this is just a brief table summarising some of the important studies that have come out in the last sort of 5 years. The Women's Health Initiative, which is a very large study, over 48,000 women, looked at the low-fat dietary intervention, did not significantly decrease the risk of heart disease. PREDIMED, which was the Mediterranean-style high-fat diet, showed a reduction in cardiovascular events just with diet by 30%. That was reanalyzed this year. They got the same results. The PURE study by UNSW, published last year, showed that a higher dietary consumption of carbohydrates was associated with the increased risk of all-cause mortality, and a high consumption of dietary fat was associated with reduced mortality. The Chimani study, which was this amazing study of this tribe of hunter-gatherers in the Amazon, who showed the lowest rates of coronary artery disease of anywhere in the world in the population, had a diet of unprocessed natural foods, plants, fish, and wild game. And then fruit and vegetables is also shown for reduced cardiovascular event. This is just a very brief study looking at the pure study, and I think Doran's going to talk about some fats a bit in his talk. But what I draw your focus upon is on the very right-hand side, the energy from carbohydrates. The greater your energy from carbohydrates, the greater total mortality, both in cardiovascular disease and total mortality. And when you start to add more fats to the diet, the lower risk of lower cardiovascular event rates. So this was a sort of a landmark dietary study. But I want to give you some examples of some patients in my practice that I've worked with Dr. Paul Mason about how we've made some changes, and we've actually been able to measure cardiovascular outcomes objectively. So firstly, in blood pressure. So we have a patient, a 62-year-old female. She's had a history of high blood pressure. Initial evaluation of blood pressure was elevated, 155 on 95. I'm still on some tablets. So what I do in my rooms is I do something called pulse wave analysis. So this is where we look at arterial stiffness, and the stiffer your arteries, the greater your risk of cardiovascular events. Once you've got a pulse pressure above 50, your risk of stroke is very high. And so we also look at central aortic blood pressure as it's coming out of the heart. And this is all a very non-invasive method, and it's just a small picture of the device. When she first came, she had an arterial age of greater than 70. She had a pulse pressure of 60. Her arterial stiffness was much higher than for age. In 18 months on low carbohydrate nutrition, she's lost 20 kilograms in weight. She came to see me for follow-up. Her blood pressure has dropped to 123, pulse pressure 34. She now has low normal arterial stiffness. Her arterial age is down to a woman of 46. She has a calcium score of 0, a non-HDL, which is 2.0, which is low, and she's going to come off all of her blood pressure medications. This sort of finding was recently published last year in a journal. It was a small study, but initially showed that weight loss using the dietary carbohydrate restriction can reduce pulse wave velocity, which is a marker of arterial stiffness, in as little as 4 weeks. Interesting, it was a greater effect in women than men. And we need sort of larger studies to confirm this, but so it made a big difference to their blood pressure. What about in cholesterol? So a gentleman come to see me, 66 years old. This was his initial cholesterol readings. And when you look at it on the surface, it's probably not too bad, but he had a high CRP. He was newly diagnosed diabetic, so HbA1c is make diagnosis of diabetics. He had a positive glucose tolerance test. But also, some of you might have had LDL subfractions. LDL subfractions is a way of how we look at how atherogenic or how likely your cholesterol is going to cause plaque. And this man had a type B pattern. He had lots of peaks in more atherogenic cholesterol, more atherogenic LDL. 6 months on a low-carb ketogenic diet, he dropped his triglycerides from 4.9 to 2. LDL was similar, but in 6 months he changed his profile to a type A profile. He lost his peak in small LDL-C. He is now not diabetic, has a normal glucose tolerance test. Statins do not change whether you've got more atherogenic LDL or not. So this was lifestyle change by being on the diet. And it was just recently published in Cardiovascular Diabetology, just this year, some of the expected biochemical changes you might see on a ketogenic, on nutritional ketosis. So where there's the majority of the blue on the left-hand side of the screen, these are the things that they found. So people on 1 year on a ketogenic diet, they reduced their HbA1c, they reduced their blood pressure, they managed to increase they reduced their ApoB, which is more atherogenic, atherogenic cholesterol. They all reduced their triglycerides to HDL ratio. They reduced their inflammatory markers significantly. They managed to all reduce their cardiovascular risk, reduced statin usage, came off antihypertensive medication, especially diuretics, which often we use for fluid retention or as part of the usual blood pressure medications we use. This is a great, early study to look at the change in biochemical markers. I'll talk very briefly about atrial fibrillation. This is a disease I see in my clinic all the time. There are 2 reasons why people get atrial fibrillation. One is on the left, it's an electrical disease. Often you see this in people who've had heart surgery, people who are athletes, but for the majority of the population, it is systemic metabolic disease. And all the things we talked about before contribute to atrial fibrillation: arterial stiffness, diastolic dysfunction, obesity, diabetes, sleep apnea. So this is a systemic disease. It causes an irregular heartbeat. It makes you more likely to have a stroke. The treatment is often, blood thinners or even, intervention into the heart. And the treatment for the majority of people is they've got to do lifestyle management. And I believe so strongly in lifestyle management after a study that was published by an Australian group, that we've actually started a lifestyle management clinic for atrial fibrillation in Macquarie University where I work. And AF is associated with significantly increased of stroke, dementia, myocardial infarction, and a significant increased risk of mortality. So it's a serious disease. It's a disease that as we get older and with the metabolic syndrome. This is an example of someone that came to see me. He'd been in AF for 4 years. That's a fairly long time to be in atrial fibrillation. He lost over 25 kilograms. We did the weight loss. We successfully cardioverted, did electrical reset, heart back to normal sinus rhythm. He's got no need for some of the medications, some of the strong antiarrhythmics for AF. And hopefully we'll be able to take him off his blood thinners as well, which is the standard way of reducing stroke risk in atrial fibrillation. So, this person's done very well with this. And this was based on some studies done by an Australian group in Adelaide, and they showed that if you have atrial fibrillation, if you were able to lose greater than 10% of your body weight, the majority of people were atrial fibrillation, free after sort of a follow-up of around over 5 years. So in actual fact, for most patients, weight loss should be the first line treatment in atrial fibrillation. That message has not got through to a lot of our medical community yet. And if you're medical people, if you've got patients in AF, you should be really pushing, weight loss to treat their disease. And that is it. Thank you very much, everyone.